posterior femoral cutaneous nerve, pain, block, and treatment. In this lecture, I will cover a relevant anatomy. We'll go over causes of posterior femoral cutaneous nerve neuropathy, the clinical presentation, what's the differential diagnosis, how we do a nerve block, and how we diagnose the condition and the treatment. So let's start. First, the posterior femoral cutaneous nerve, it arises from the sacral plexus, specifically from S1 to S3. More specific, from the posterior divisions of the anterior rami of S1 and S2 and anterior divisions of the anterior rami of S2 and S3. What's relevant for us here, so I took out the gluteus maximus muscle, so this is underneath that, the gluteus minimus, but the gluteus maximus come from here and cover this area. And then you see the piriformis, and then underneath the piriformis you see the sciatic nerve, and just medial to that you see in the pink color the posterior femoral cutaneous nerve. I want you also to see the obturator internus muscle and how it goes underneath the nerve, and then the hamstring muscles that they attach here, which consist of three muscles starting from lateral to medial: biceps femoris muscle, semitendinosus, and semimembranous muscles. So the nerve passes through the great sciatic foramen and underneath the piriformis muscle to enter the pelvic cavity. It descends inferior to the gluteus maximus and fascia lata and superior to the sciatic nerve and long head of the biceps femoris. The nerve terminates by piercing the fascia lata in the popliteal fossa to give branches that join with the sural nerve. Well, that's what we know from all the anatomy book. However, there is a recent study that was published a couple of years ago. It shows that actually the nerve goes beyond the popliteal fossa. So only in about 10% it ended in the popliteal fossa, while in most of the patient it terminates in the proximal and distal lower leg. This nerve is a pure sensory. It supplies the back of the thigh, including the popliteal fossa, inferior half of the buttock, and posterior part of the scrotum and labia majora through the perineal branch. Causes of peripheral femoral cutaneous nerve neuropathy. The most common cause among these four causes is the surgical injury. Typical presentation: patient after hip surgery. The nerve can be injured from retraction, the manipulation itself, and the tourniquet, especially if we have a long time tourniquet. The longer the time, the higher the risk. So as you imagine, any tourniquet that goes in the upper thigh, that also can cause similar issues. And also lower limb amputation, and then skin graft harvest from the posterior thigh. Another common scenario or cause is the prolonged sitting on the chair, specifically at the edge of the chair, if you have this kind of habit, that compress the nerve and can occur as it occurs in the ischial tuberosity. Now, this is also can be a cause of sacroiliac joint dysfunction and piriformis muscle. Another possible cause is the prolonged bicycle. That's also similar to piriformis. And then intramuscular injection, if you end up going in a wrong place, you can injure the nerve. So also notice that the posterior femoral cutaneous nerve, along with the pudendal nerve, they go together through the greater sciatic foramen after passing through the infrapiriformis canal. So they can be trapped together along this path, and the patient can present with both symptoms. Risk factor, cachectic patient, people with muscle waste, and also obese, smokers, and diabetes. So typically the patient present with gluteal fold and upper thigh pain. That's the dermatome that's covered by the posterior femoral cutaneous nerve. And this pain is typically triggered or exacerbated by sitting. Most of these patients, they do well with standing and walking because you didn't have that pressure anymore. The pain is classically neuropathic. Patient usually prescribe it as burning pain, and they might have burning along the distribution of the nerve, this blue color here. In examination, you might feel some tenderness here or along the side of the nerve. But it's important in the examination to rule out sacroiliac joint dysfunction and piriformis syndrome. Injury of the pudendal branch can also mimic pudendal nerve symptoms, and usually you have abnormal sensory exams, like if you do sensory exam and compare it with the other side or the anterior part, but you shouldn't have any motor deficit. This is overall a rare condition, so most of our knowledge from case reports. So for example, this is a paper that was published in 2015, and they studied 6 patients. So as you see here in the symptoms, pain mostly, like here, right popliteal fossa radiate to the mid-thigh, or pain at the dorsal left thigh, posterior aspect of the right lower thigh, severe pain radiate from the sciatic tubular to the popliteal fossa. This is why commonly this disease mistaken by sciatica. Pain in the gluteal fold, I have seen it multiple times, and severe pain when bending over. History, marathon runner and remarkable lower limb amputation, iatrogenic hamstring injury again, and here a post hip replacement, which I have seen a few of these patients. And you may or may not see scar at the examination. Now, this is a nice summary slide. These are the differential diagnosis of chronic buttock pain. So if you have acute buttock pain, especially if you have a history of injury, the differential diagnosis can be different, including fracture, and that's needed different approach. But here we are talking about chronic buttock pain that lasts more than 3 months. So the way I like to think about this, I like to classify this to 4 different presentation. So if the patient use the entire hand to point to the buttock pain, I call this non-specific. So most likely this can be a referred pain, either from facet joint disease, lumbar facet joint disease, or central canal stenosis like neurogenic claudication, or a radiculopathic pain that's going from the back and shooting down. Also myofascial pain or some cutaneous diseases like you name it, lipoma, infected follicle, etc. If the patient if the patient become more specific and use 2 fingers, or one finger and point it, then I divide the buttock area into three thirds. The upper third, then most likely these patients may have sacroiliac joint disease or superior colonial neuropathy. If the patient pointed in the middle one third, then most likely this is piriformis, colonial neuropathy, sacroiliac disease, coccydynia. If it's in the middle, there is some overlap here. It's not a concrete rule. What I found it more classic if the patient pointed in the lower third and put their fingers at the gluteal fold. That can be a posterior femoral cutaneous nerve neuropathy or obturator internus tendonitis and or bursitis. Hamstring tendonitis also can present like that, and SQ gluteal bursitis. So as you see, there is a wide variety of differential diagnosis. Just because I want to make this lecture short, so I'm not going to go in details over them. But here is a useful dermatome picture, and here is you see the bursa, and here the nerves that can cause neuropathy. Okay, so let's jump in and see how we do the block. So before I show you some pictures, let me give you a few tips that I found useful. First, the posterior femoral cutaneous nerve, usually it's a hypoechoic structure, usually. Now again, I use usually because there is nothing 100%. The first step I usually do is to find the nerve, is to chase the biceps femoris or the hamstring along long head and go up. Usually the nerve is lateral to the biceps femoris. I'll show you a few pictures here. It's easy, you can even palpate the biceps femoris head and you put your ultrasound right there. If you see the medial circumflex femoral artery and vein, you are probably lateral and you need to move medial. The posterior femoral cutaneous nerve remain subfacial in the gluteal region. It's below the fascia lata, and usually it pierces and go above the fascia lata as it passes the gluteal area. And then locate the sciatic nerve always. It usually at the subglottic area is usually underneath the biceps femoris because you want to avoid that. And then the nerve lie between the biceps femoris and the gluteus maximus muscle. So usually just medial to the sciatic nerve. The nerve emerge beneath the distal edge of the gluteus maximus to follow the groove formed by the long head of the biceps and the semitendinosus muscle. It is easier to find the nerve in the mid-thigh. So if you cannot see it there, go down. You can start from the popliteal fossa and chase it up, or from the mid-thigh. Nerve stimulator, I found it very helpful, especially if you are in doubt. So if you turn on some sensory stimulation, the patient, you should recreate or the patient pain. So the patient will tell you that, okay, I feel it going down my thigh. And then test motor. You should not have any major contraction. Remember, if you have major contraction, they are probably very close to the sciatic, so you need to redirect the needle. If you are doing a block, make sure you are above the deep investing muscular fascia of the thigh to avoid local anesthetic spread to the sciatic nerve. I'll show you a lot of pictures now. Okay, so most likely, especially for chronic pain, we're talking about chronic pain, you would like to block this nerve at the subglottic area. So as you see here, this is the lateral, this is the gluteus maximus, and medially you have the biceps femoris, and underneath that the sciatic nerve. Notice there is two facial line here. The yellow line represents the fascia lata, which is above, just underneath the gluteus maximus, And then in the blue line, you have the deep investing muscular fascia of the thigh. So as long as you inject above the deep investing muscular fascia of the thigh, you most likely would not have a spread to the sciatic nerve. If you pierce through this, you will get the sciatic nerve, and you will not get a good block for the posterior femoral cutaneous nerve. So this is important to watch for that spread when you do the nerve block. Now, it's a nice habit if you scan up and down just to confirm. So if you are scanning up just at the level of the piriformis, remember the nerve is underneath the piriformis and medial to the sciatic nerve. If you scan farther down, that's the gluteal fold, and then specifically for this patient, this is the hamstring or the biceps femoris head, and the sciatic tuberosity underneath that, and then here you have the sciatic nerve, and here you have the posterior femoral cutaneous nerve. If you keep going down a little bit, that's the subgluteal region, and this is a flipped image from the previous. So this is medial here. This is your gluteus maximus, and this is the biceps femoris. So this is the fascia lata, and this is the deep investing facial layer. So between them, you will see the PFCN nerve. If you keep going down, this is proximal thigh. Notice the nerve become even more superficial. As I told you in the previous slide, the nerve, once it passes the gluteal region, it jump above the fascia lata. But in this case, it is actually underneath. So there is some anatomical variation here. And here, if you pay attention, there is a neuroma attached to the nerve. Here, where we keep going down, this is the apex of the popliteal fossa. Notice it's above the fascia lata, and this is medial, and to the medial side you will see the tibial nerve here. So it is medial to the tibial nerve. You will see the hypoechoic PFCN. This is another picture. This is how you place the ultrasound probe. So this is medial. You have the biceps femoris here. You have the gluteus maximus. And then, if you pay attention, that's the fascia lata here. And that's the other investing fascia here. And then that's your sciatic nerve here. So this hypoechoic structure is the PFCN. And you come and you see here the artery and the vein of the medial circumflex femoral. And if you see them, you just need to go more medial. Then you bring your needle from lateral to medial and do the block or the radiofrequency treatment. Okay, so how we diagnose this? You probably can do EMG or nerve conduction study, but this is a small nerve, so this can be inconclusive and not very specific test. You again can do MR neurogram, but again, this is a small nerve, so it might be missed, but it can be seen also. I think the best diagnostic test is just to do a nerve block and see if that will take care of the pain of the knot. And finally, if you confirm the diagnosis, You can try pharmacological treatment like anti-neuropathic pain like gabapentin, Lyrica, duloxetine, you name it. Interventional treatment, you can try steroid nerve block, especially if it's a fresh injury. You can try also hydrodissection if there is entrapment. Radio frequency neuromodulation, pulse usually I do. Cryotherapy is possible, and peripheral nerve stimulator can be done, and finally surgical decompression. These are my references, and thank you for watching.